kind of take it across the US in general, because there is a huge problem right now associated with rural healthcare and the lack of coverage for many people in this country. But as we look at moving in towards any sort of emergency response, that is quickly being thrust back on the states. FEMA is not going to support that. In fact, there was a tweet from them today that said, "Hey, if you have any neighbors that have gone through bad weather, you might talk to them as to how to survive this storm." And while that's never bad advice, that also basically says you're on your own, America. So it speaks to, again, the growing disparity in availability of both services and coverage, specifically associated with healthcare and emergency response, but the need for something which is really tailored to the way you do work and the way that people in these environments have to do work.
Mhm.
So, yeah, then to Jim's point, we have experience doing that around COVID, around other large scale responses. And that's kind of what we built the platform to be able to do, is work, whether it's connected or disconnected, to be able to actually support delivery of care.
Mhm.
So, but my point to Jim was I would love to have a deeper dive with Jessica to see what really are their specific needs from an administrative, process flow standpoint. Where could we make the biggest impact, the biggest bang for the buck? And quite often, and Jessica, I may be incorrect, you may be part of the administrative team that runs the clinic. Quite often, the people that are at the edge and delivering care are not. So identifying from you what you need to be better, to make it easier to do your job more effectively. But also, are there any points of contact inside of your organization that would be good for us to talk to as well? Because as we're looking at pitching, whether it's the Virginia governor or Maryland or wherever, we're looking at West Virginia, having something which has really been validated is absolutely critical,
Mhm.
and makes it, number one, easier for us to know we're doing the right things, but secondarily, to justify any sort of money that we get, and then have something to measure against as we're going forward. That was certainly critical in the CDC grants and HHS grants that we've had previously that we used to build the platform. And that's the way I've always done this anyway, regardless of who the client is. So yeah.
When you were talking, the one thing that really just hit my mind as far as like what I kind of deal with every day
Mhm.
was thinking about you were, in a car accident in a place that's not your normal home.
Yeah.
If you would have had to go to a hospital or emergency department in that area, if you don't take your records with you, you're calling to get your records later.
Mhm.
Because sometimes they have different platforms in which your normal people don't have access to.
Correct.
And that is something that drives, I think, all of us a little nuts, is that yes, we can see things from other places, especially usually bigger hospital networks.
Mhm.
But I think it's very, very cumbersome in trying to understand what their documentation is in their platform quick enough for me to look at it, understand it, see what was going on, to then try to process what's in front of me with a patient is
Understand.
very, very difficult.
Okay.
Takes forever. Nobody wants to go through 30,000 pages of somebody's medical history from somewhere else.
Yeah.
And that's what it is, because most of it is just stuff we don't need. It's timestamps.
Mhm.
So and so drew blood at this time to send to the lab at this time with this gauge needle. I don't need
Mhm.
to know that. I don't really care about that. I want to know what the results were. And
Mhm.
then 5 pages down, we get the results.
Yeah.
If there could be some kind of platform built in that would somehow go through, connect everybody, so have it funnel in,
Mhm.
go through it and hit the high points of here's the results, this is what happened, here's what we did for them as far as care.
Yeah.
We discharge them with X, Y, and Z to follow up with you.
Mhm.
That would be incredibly helpful.
Okay. There's several things you touched on there. One is, yes, the lack of interoperability between systems is a huge problem. And I'm actually a co-chair in HL7 for process automation, specifically in healthcare. Um, and HL7 has been working for a very long time, specifically on health interoperability, but because it's not really required, and because the standards allow for you to implement them the way you want, FHIR implementations between Epic and Oracle, as an example, what used to be Cerner, very different. The data you
Mhm.
get in and out, very different. The core descriptions and the security, that's standardized, but the data is different. And it all depends on the information model. What EHR are you guys using?
Epic.
Okay, you are using Epic. So getting the data in there, that's one step. So that's the outer door, right? We're going to make the call, we're going to pull in. The other point you brought up is the lack of a national HIE, which is unfortunately something that several people are trying to fix, but even Gorilla Health or anybody else truly don't have a single solution. And in fact, Gorilla was just sued by Epic for apparently distributing data more effectively than Epic would like. Um, so, so yeah,
Of course.
so, yeah, shouldn't have done that. But to your point, I think that is one problem that people are looking to solve. We certainly could help with a plugin, getting that would make it easier to gather the data, do the translation, and then push it into the information model so that Epic could actually distribute it to you. Because we've got core algorithms that do that assessment and go, why is this person here? And then we search across that. So we're able to make those records searchable. Because to your point, yeah, I was talking to a friend of ours who's got a concierge PCP practice, and he has a similar problem of getting data from Inova into his, and forget which one it is, but it's one that's built for PCPs. What he ends up doing is opening up Epic and opening up his and creating a notepad and scrolling and finding, and okay, this one's a doctor, not a nurse, and it's not a blood, and it's not this, and and pulling out, creating in his brain a synopsis that he then pastes into his EHR to provide some sort of history, which is meaningful to him to care for this patient. And that takes easily an hour for every new patient that comes in. Or if he's playing catch up with a patient he hasn't seen for a while, have they been hospitalized? What was the outcome? Da, 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 da. So that is a huge problem, regardless of what EHR you're using, to be fully honest, because
Yeah.
they record everything, especially for
Mhm.
inpatient,
Mhm.
because they have to, right?
They have to, right, right,
You have to. And
right.
you bill for every single one of those things.
Everything, yeah.
So
And you have to, because if you didn't, then you wouldn't get reimbursed, and there's just,
exactly.
it's
And
just a
Epic
whole.
makes you do that by its workflow.
Yes.
So that's the other big problem that we've identified associated with EHRs is the workflow. So the platform that we built allows for care providers, whether they're in our case, we were deploying with social workers, temporary hires, a variety of people into the field to go into homeless encampments, things like that, and actually engage with patients initially around just have you been vaccinated? And if not, why not? Because CDC was not getting that data back. And then we improved their collection of data in general to where they were getting reports weekly via or versus monthly or quarterly. So, but key there was streamlining the workflow and making applicable clinical data available. So we modeled what they were actually able to do in the field and basically created a platform that could support that. We can support any sort of clinical flow because we sit either on top or around the EHRs. So that sort of assessment that we just talked about of saying, what is it that Jessica needs to see? Because the patient's here for this. Do they have any history of this? Do they have anything even slightly associated with this? We're going to bump that up to the top and make it easier for you to discover it. Now you can click in and do a search and see everything if you want to see the full history.
Mm-hmm.
It's not, making that go away, but it is at least raising up, prioritizing the things that are applicable to the reason the patient is there. And also prioritizing any elements that are associated with chronic conditions, like you need to have a blood check because last time you were here, you were borderline diabetic. So because that stuff's not going to show up, right? So being able to streamline that engagement, but all that took is all that to be able to do that took several discussions with people like yourself to say, if you could do this effectively, what would make it easier for you? What do you really need that you're not getting?
The fact that it can be done makes me happy.
Oh, absolutely.
I was gonna say another thing that we constantly, our network really works on trying to make sure we meet certain goals with CMS, right? Like we have to meet goals, and those goals are they change every year, right?
Oh yeah.
It would be nice if that was like built in. To also look at our patients and everything, like are they pre-diabetic? Do they have an elevated A1C? Our goal is to get their A1C under 8 if they are diabetic, and keep it that way. Are they getting their lab work every 3 months?
Yep.
Having that infiltrated would be super nice, because again, I'm seeing like 22 patients a day. That doesn't leave me a lot of time to put all of that in, which I think we use DAX Copilot. Have you heard of this?
DAX Copilot.
DAX Copilot with Epic.
Okay.
So it's an AI generated, basically like dictation is what I would call it.
Okay.
So it's on our phone. It's an app out. It's an Epic app. It's built into that. We put it in, take it in the room with our patients, hit start. It listens to the entire conversation, helps us write our note.
Okay,
Problem
so it's a note-taking app.
So it is. Well, kind of built into Epic. It's Epic's version.
Yeah.
Yeah. I think in the future it's coming that it's supposed to, maybe this year, start dropping orders while we are talking with our patient, which is going to be helpful. But I still don't think that it's going to like look at health maintenance or follow-up labs. So sure, we have diabetes, we need an A1C. Well, if the A1C is greater than 8, we need an A1C every 3 months until we get it under that.
Yep.
And so recognizing things like that would be super helpful, which I have my point of contact. I have tried to say, hey, can we figure that out? The other aspect that I really, really, really wanted to talk about is our in-basket.
Okay.
Which is, do you know what an in-basket is?
Tell me from your perspective.
From my perspective, it's where all of my labs and test results come into, all the questions, patient calls, all of that. Okay. I spend all my day seeing my patients, and then at the end of the day, I have this massive in-basket, which truthfully, after our meeting today, I will probably be sitting and working in my in-basket.
Yes.
Answering calls, answering labs.
Yeah.
And one of the major risks or problems there is that you're losing the context after the time you get to it, right? Is that still? Yeah.
Yep.
So all those subtleties you've forgotten or gotten consumed, and okay.
Yep. That's definitely an issue. But also it's a lot of time of my day that I'm not even getting paid for.
Yep.
Which drives me nuts, because it's like, 50 to 100 tasks each day.
Yes.
Yeah, it's a lot. And so it would be nice to also have a way that we could use this Copilot that we have, which again, my point of contact person, I'm like, is this ever going to be a thing? Can we look at the results, have it open, talk about, oh, this patient's cholesterol was really high. I'd really like for them to come back in 3 months, have that rechecked, maybe do a telehealth to discuss it.
Excuse me.
Can I do that? Can it put those lab orders in? Can it send the message to my care team to have them call and just let the patient A, know the results, B, get them scheduled?
So there are ways to do that. Epic was probably the worst that we looked at doing that with. That's why on a couple of the grant-funded engagements, we ended up going with Athena-1. Because Epic had a workflow that wouldn't let you, in the case of this single grant, it was associated with HIV testing. CDC wanted to increase that. Epic wouldn't let us do anything. It would let us push it into a panel where the physician still had to go in, or the nurse still had to go in and select and initiate that push to the lab to make something happen. Epic simply, their workflow simply would not allow it. The governance would not allow it.
Their workflow drives me insane throughout
Yes.
my day because of that. Because every time I want, let's say a patient calls, the nurse is in front of me, the patient's on the phone.
Yeah.
And they're like, hey, this is what's going on. They're at the lab now. They need orders for this lab work.
Yeah.
Perfect. Great. Well, it's going to take me 5 minutes now because now I have to look the patient up. I have to click in. I have to open an encounter. I have to document why they called. I have to put the lab orders in. I have to click that it's okay, make sure that it's timed correctly so that they can get it while they're in the lab right now on the phone. And it's just, while I'm trying to get to my next 3 patients, it's just such a terrible workflow. But it works. It works. It's just a lot of extra steps.
Exactly.
That I feel like moving into the future, we could try to get rid of.
Yeah, no, absolutely. I mean, these are common issues that whether you're rural or otherwise,
Yeah.
it just becomes a bigger problem, I think, for you, and I'm assuming here, simply the sheer number of patients. Although I hear similar things from PCPs elsewhere as well. Just
I think that's
the
probably
number of
across the
patients
board.
it's
Yeah.
ridiculous.
Yeah.
It is.
Yeah. And that kind of goes back into the number of patients that we're seeing and taking care of, kind of goes into the idea that, the biggest population this country's ever seen is now reaching the age that they want to do healthcare. They want to
Yeah.
be seen every couple of months because they're now over the age of 65 and they require that.
Yes.
And so that's just a big load of people that we're trying to take on as well.
No, absolutely. Absolutely. With limited resources,
Yep.
without getting a bump for
Yeah.
those resources. So, what is your Epic instance? How many other facilities does it cover?
Oh goodness, it covers, I want to say we have like 9 actual hospital systems from Virginia down to North Carolina. And then we have multiple. I mean, just in Rockingham County, I want to say we probably have 15 to 20 clinics outpatient.
Wow.
Yeah, just in the county, and then the next county over's got 5 or 6.
All on
And then
the
you
same
get-
Epic.
I was about to ask that question.
I'm pretty sure it's all the same because we can pull it anywhere.
Yeah.
I don't.
Then yeah.
I would say maybe we're able to access it because Sentara has the license for all of it, but I guess the same Epic is
But you're all
probably
on the
just for the.
Sentara. You're all on the Sentara instance.
Yes, we're all on the
Okay.
Sentara.
Okay. So yeah, it's all the same instance because
Yeah.
if it was separate instances, you would get view access, but it would be limited.
Okay, that makes sense. Yeah, no, because we can view.
Okay.
We can view, I think, the other hospital systems,
Yeah.
but we can't necessarily work in them. But all of the ones in this area, we can work
But
through.
you can see the records for the patients that's sitting in front of you.
Yes.
Okay. So realistically, yeah, I didn't know you were part of Sentara. That helps. So
Does that make sense?
no, that helps immensely. Whenever we're talking about how we might be able to help you as an example, what we would need to do probably is go to Sentara.
Yeah.
But having proponency at your level is absolutely critical. That's what I was telling Jim yesterday. Whether it's DoD, VA Health, whether it's any healthcare facility, any healthcare organization, it increases the return on investment when we know that physicians, nurses, the teams are actually going to use the change. That becomes a much different conversation. We can save this much time and this much energy and this much frustration and burnout by doing this one thing or these 2 things or whatever.
Yeah. Just truthfully, just having DAX recently was incredibly a big change. Like that was nice. That was nice because, again, just like Stanton said, that when we're working through our in-basket, what we did with the patient, that's kind of like not in our mind. The nice thing is Copilot records everything, and so you can go back and pull all of that out and say, okay, where did this lie? What conversation did we have about that? And that's incredibly helpful.
No, absolutely.
Not
That's
to
why we
mention the
record.
safety of it.
Well, that's why we record transcripts on Zoom now, right?
Right.
Because how many of us have had these meetings and gone, okay, what the hell? I wasn't taking notes.
Yeah.
Right,
What did Jim say?
right,
What did Jessica say? So these things are incredibly helpful.
right.
And thank God people are getting more accustomed to, okay, there's going to be something listening, but it's going to be safe, it's going to be secure, it's going to be, we still have the same constraints that we do whenever you talk to a physician, whenever we're talking, back and forth. That expectation of security and safety is absolutely critical. So in relation to that, so those are, and I think we covered, those are common problems. They're yours, so they're incredibly important. And we can certainly, I would love to dig down into what that workflow looks like when you have somebody come in. What's your step one, step two, step three? In regards to the discussion around rural health in general, though, what's the difference? Have you practiced anywhere but down south?
Nope, that's it. I've
Okay, all right,
Yeah.
okay.
Well,
Is it-
and
Go ahead, Jim.
just one thing, Brandon Rivenbank, who I think Ken, Jessica, and I know, he is the Virginia Department of Health Rural Healthcare Manager.
Yep.
So I can connect us anytime, and he has echoed exactly the same sentiment that Jessica has said about the software systems. So
Oh yeah,
he might
no,
have
it's a common problem.
a high level
Yeah.
perspective of presumably or ostensibly all the RHCs in Virginia. So if we need to get to him, he's very open to having a chat.
Yeah, I think as we look at rolling up, because again, this is not an Epic problem. This is EHRs in general. Epic has its own unique BS,
Yeah.
such as the inability to effectively kick a lab off automatically in an automated way. You have to go through that additional secondary review and everything else to go to the order panel and select. You don't have to do that in Athena. It all depends on the EHR, but having the logic behind the scenes that looks for this stuff, that aggregates the data, that brings it together for the patient that you're seeing, and doing that in advance when you have a scheduled visit, it's actually a much easier task than if it's an emergency visit. To my earlier reference to the car crash. I had records in Satara from Virginia Beach, but luckily I didn't need to use them. So,
Yeah.
but so I think in that, and Stanton, I see your,
Oh,
were
I
you
was
gonna
just
ask
I was
something?
just gonna say, Jessica, my brother is a doc, and he's on Epic at Mass General. Um,
oh
and he
nice.
deals with the workaround by tasking any underling available to do all of his notes. That's really, he hates them more
Right?
than just about anything. So yeah, he's like, either I don't do them or I make some poor Stucky do them. He's like, that's pretty much what happens.
I used to have a scribe, which was the best thing in the world, and then
Right.
she decided to have a baby and hasn't been back and won't be back, and so now they're
Inconsiderate.
like, yeah, I know, and now they're like, yeah, we're not going to get you anybody else to help you, so you're on
Oh
your own, but here's some DAX.
I'm sorry.
Well, luckily, Dax is not going to get pregnant and leave.
Thank goodness.
We hope.
Well, not
He
anytime
might
soon.
develop sentience and just decide I've had enough.
Well, then there's always another bot for that. So,
It might be. Sometimes I say not so nice things to it.
and it records that.
It
Yeah.
does.
Yeah.
It does.
It is now part of the permanent record, Jessica.
I know.
Oh, it's funny.
So what other, so we've talked about data accessibility. We've talked about really data discovery. What other issues do you guys have as far as, how about care coordination? How do you handle that? Because right now it's, everything you've described is off of you, and hopefully your patients have been seen specifically in the Centara system, so you can do that search as much time as it takes. You can still do that search. how do you handle care coordination with physicians that aren't in the Sentara system? How do you pull that data together? What do you rely on? How do you deal with the gaps?
That is a painful thing. You basically just call their office and hope that somebody faxes you something or the patient brings it with them.
Okay. How
And that gets
often?
really tricky when they're like
Yeah.
out of state.
Well,
Yeah.
precisely. And I recall that being, that you mentioning that during one of our group calls, that it seemed like you were seeing patients from West Virginia, you were seeing patients from other areas, right?
Yes. Yes.
Okay.
In West Virginia. So, one thing that drives me nuts about seeing my patients from West Virginia, especially children, is that there's no bank of vaccines. There is no database of vaccines for West Virginia.
Really?
No, they don't keep one
Um,
that I'm aware of.
do they have their little vaccination book? Do they have anything?
I'm sure parents have that if they keep it, but
If they remember to bring
if
it
they remember to
too,
bring it,
right?
yeah.
Yeah.
Where like we can go into VBFC, which is our bank,
Mhm.
and we can pull vaccines, but they come from West Virginia. And I mean, it's a guessing game.
Okay.
Parents are like, well, we went to this one appointment and they got like 3 shots, I think, that day. And then at the next one, I think they got 2. And I'm
Yeah.
like, I
Who's
mean,
gonna
that's
remember that?
tracking.
Yeah,
Right.
exactly. No one's gonna remember that.
No.
Yeah.
No, I mean, patients can't tell me what they're taking as far as medications, but they take, a green pill and a white pill and kind of a square looking pill.
Yeah. Are you guys using anything for patient outreach, patient coordination, actual, is there, whether it's an app or is it
Like,
really on admin staff to call and follow up and things like that?
so we do have a my chart, so people
Yeah.
but I mean, I personally don't even get into my chart.
Yeah, it's not really I mean, yes, you can send secure messages, but it requires additional logins. It's not quick.
Mhm.
There's no easy way to send somebody and say, "Hey, Jessica, what's your pain level like today?"
Yeah.
And just quickly check in.
It's really more our chart than your chart.
Yeah.
Mhm. Yeah, yeah.
It's
Who's
really
the
ethics
R?
chart.
Yeah,
Right.
I
exactly.
don't
Ethics
And we
even.
don't mean the client. Yeah, exactly.
Right, right.
No, I was gonna say, yeah. And what's ridiculous is we actually recently just went to about a year ago. Actually, we went to like a centralized scheduling and a centralized call center,
Mhm.
and that has been quite a learning curve for us because most rural patients can call their office and say, "Hey, I'm not feeling well today. Can I
Yeah.
get an appointment?" Well, now it goes to like a phone tree
Yes.
that then goes to a nurse call center that they
Yep.
have to talk to a nurse and not anybody in our clinic. And then that nurse decides whether they need an appointment or if they need to go to the ER, which also drives me nuts because I don't want my patients just going to the ER with their snotty nose because I don't have an appointment available.
Yeah.
That's ridiculous. But
It
it's
is.
happening.
It is. It is. Oh, and yeah, we can't really solve that. Um,
Yeah,
that's a much bigger corporate decision, and unfortunately, that's common, right?
right.
It's
Yeah,
the same with Inova.
right.
Yeah.
So, with having that, we've been trying to get people to maybe use their My Charts a little bit more to send us messages that then goes to the pool that then we can pull from.
Yeah.
But again, then that's rolling into our in basket, which
Exactly.
is just incredibly cumbersome.
Yes.
I can clean my in basket out. Like I cleaned my in basket out yesterday and I think I had 4 tasks to do.
Mhm.
I guarantee you I can open it right now and it's probably like at 120.
No, it piles up, right?
Oh,
Because
quickly.
you have one central collection point, and there's no prioritization. If
It's
you
basically up
collect,
to our nurses to prioritize what needs to be sent to us and what doesn't. And my nurse does a terrible job of it right now, so I'm
Okay.
actually doing it myself.
Okay. So
I mean, yeah, I'm just shocked, but not surprised, I guess. It's just, I mean,
this is, I think, to everything else, a lot of what Jessica has shared, Jim. This is healthcare in the U.S.
Yeah.
Whether we're talking to VA, VHA, DoD health, that DoD's probably got the best control over it because it's active duty, and then they outsource for any of the dependents for most of it. But VHA has the same problems as commercial healthcare.
Yeah,
It's
my
everything
bias,
Jess has
I would
described.
assume the DoD had the worst, but you're telling me it's the best?
Well, DoD is the best. So VA probably has more control for any services that are delivered within the VA itself. And
Wow.
then their contracts are a little bit better for third-party providers underneath community care. They get more data back than they used to. But that's all about changing the contracts. Now, does that mean that they're fully aware of everything happening with you? No. The main reason that they are is you have to get a referral for anything through community care. So there is at least that checkpoint. But getting the full data for the treatment, that's not in there. The only reason my orthopedic specialist is aware of any of the issues I had with my knee replacement is because I took my record and showed her. So that's, yeah. Yeah, so everybody has the same problem. Data communication, data getting back and forth, care coordination is a huge problem. That's why we've targeted it with the platform, and that's why that's what we try and help. Jessica is to really solve and fill those gaps. That's why we had the patient app that allows for the communication, but more importantly, the patient can carry the record with them. It's not, let me log into my chart and show you my crap.
Yeah.
Yeah. Because that sucks. That's the worst. Especially in an emergency situation. Really, you're going to log into my chart? No.
No. No. No.
Yeah, when we do, just real quickly, and Jessica, since you've got this workload, I also want to be mindful of keeping you on the phone. But just to that point, we run into that in operational medicine stuff even more. It's a shorter timeline, but it's even more pronounced, right? Because they're still facing, you either document care or you deliver care. And they have that reality, which is why they end up drawing on them with Sharpies when they put them on a plane, right? Like, because it's just, even 40 years after first realizing this and realizing the tech that we needed to do to fix this, we're still it's almost like every day's Groundhog Day sometimes. And
absolutely.
Yeah.
And unfortunately, I have to leave. I have to drop in 5 minutes. So, what other questions do we have for you? I would like to schedule a follow-up.
Yes.
Just to do a bit of a deeper dive when you have time. I don't know what your schedule looks like.
It's awful.
And I would imagine it is awful. I just heard that there's a lot of pajama time, and that sucks. I hate that they call it pajama time because that makes it sound like fun.
Yeah, right.
Yeah.
Cup of tea and your records.
You should be asleep, but instead you're affecting a patient's notes in their record, and yeah, that's not good. That's not good.
No.
That means you haven't had sleep, you haven't had sufficient rest, and you're even in a worse position. Thank God you have Copilot now to help a little bit to give you context. But still, are we at our best when we've been going for 24 hours without sleep? I don't think so.
No. Burnout is real.
I know.
So what would the next format be useful, like, Ken, for you and me to come back with some concepts, some slides around what she's laid out, who we would talk to, like what our next ask are?
I would like to do a quick deep dive into just kind of your process for you when you get a patient. Identify kind of within that flow, where could things be better? And because again, what we're attempting to do, right, is to not only highlight, okay, we know this is a problem in healthcare in the US. And if we can answer that, super cool. But we also have these monies that are being distributed around rural healthcare that we want to be able to tie it to that from a story perspective and from a messaging perspective, so we can get that money and actually solve your problem. So, care coordination is always a big problem, right? The influx of patients versus care providers, huge problem. So the information issues that we have around that, we know that that's a target. If we could get it a little tighter as to, in your care, this is how long Jessica takes to have to go into Epic and search for this crap and then sift through it and then come back and be able to really prepare for her patient. If we could cut 30 minutes down to 4 or 5, if we could cut an hour down, now we're talking about, okay, around rural healthcare, to your point, the number of patients is only growing. They're aging, so the number of chronic conditions is growing exponentially. And let's be honest, people in rural communities often don't take the best care of themselves. So, because you drive everywhere, right?
Yep.
Walkability is not real. So
No.
you might get hit by a truck as you're trying to do your walk. So, more than likely you will. So being able to highlight in there where you feel the biggest impact would be for you in just this simple workflow, and being able to then go, every one of your physicians is doing this. And they have to, because again, patient numbers are growing, patients are getting sicker. We've talked to Jessica. Obviously, it would be ideal if we could talk to a couple of other providers that you would recommend we talk to. Do that mapping and be able to show, with this sampling, just with these few providers, here's these 5 areas that we could make a major impact and we could see return on investment, and let's get a pilot started. Now the conversation shifts to, well, how much and, when could we schedule it and things like that. But what we want to do is wrap this as simply, basically give the organization an easy button to say, yay, verily, we need the money to do this. And they may already have some of these initiatives in their pipeline, but that's a discussion with administration to say, how many of these things are you actually addressing? And could we help you in jumpstarting some of these things?
Okay.
Yeah, that's all.
Okay.
That makes sense?
So I think I would like to get a contact for you for maybe who kind of does our big IT stuff for the hospital, for the Sentara network, just in our area. Yeah. And just see if everything I talked about is on their radar, number one, right? As it should be on their radar. Yeah. Right. And then I think that would probably be a good conversation, or at least for you to be able to talk to them. And then in the meantime, I think me just having maybe some conversations with the people in my clinic, and maybe see if maybe one of them was to get on and maybe talk as well.
That'd be awesome.
Yeah.
That'd be absolutely. That we have found that I've found that to be incredibly helpful. I've used Health Geeks and other groups to be able to find people in emergency rooms and stuff like that.
Yeah.
And connect those same dots, right? It's incredibly helpful though to get the localized information to say, no, at this clinic or at these 2 clinics or these 3 clinics, here's the problems they're running into consistently. Maybe Epic has this in their pipeline to somehow answer this at some point, but is Sentara big enough to make Epic turn left now? Probably not. Let's be real. I mean, because God knows DoD and VA have tried to do that with Oracle, and you would think, and they're the biggest healthcare provider in the world.
Oh, wow.
And they still haven't been able to and they've given Oracle billions of dollars. So, and they still haven't been able to get things fixed, right? They're still doing workarounds. So it's super hard. Once you build this incredibly complex EHR, it's super hard to make a huge change in it because it's not built to do that. All those rules are in there and you can't just rip them out. That's why we have a market, and that's why other companies do too, in doing this stuff outside and then plugging back in, right? So
yeah. Okay.
Makes
For
sense.
sure.
Yeah.
Well, I really appreciate the time. Thank you, Jim, for letting me totally take over the discussion. I do need to drop. There's a congressional thing that I agreed to go to. So,
I think this has been great. Absolutely, Jessica. Thank you so much, and we'll all kind of coordinate things and figure out next. And by the way, the only thing that is jumping to my brain, Brandon did say they have Meditech. Meditech. Are you guys familiar with that? And Brandon said that
is a common EHR that many of his organizations have because it's cheap.
Yeah, well, and here's what my notes from that meeting were: that Meditech wasn't cutting it; it was too expensive and cumbersome, and it's much cheaper than Epic. So
yeah.
that apparently is not solving the problems
No,
either.
it's not. No, the majority of them are, number one, there isn't a real cheap EHR out there unless you're going to deploy open EHR. And
Mm,
then you need a staff, an IT staff.
Right,
And most
right.
organizations are not willing to invest in it.
Right.
Even though it's deployed all over the world, it's being used for nationwide healthcare in certain countries.
Wow.
But getting that, we're so commercially driven in this country that, I mean, we have probably the biggest implementation of corporate of big label EHRs here, whereas in
Right.
Germany and Italy they're still using self-built stuff.
Mm.
And they have nationalized healthcare, and they're still
Right.
doing that
Wow.
because it works. And why would I,
No, right.
so
Right.
anyway, so thank you
Okay.
so much for your time.
Okay.
Stanton, go ahead and stay on if you would, and I got to jump, but thank you.
Okay. See you
Have a good
again.
day,
Okay.
and stay
And-
warm.
And Stan, Jessica knows VIPC too, and I don't know if you're going to be on the call, the coffee shop tomorrow, but Ken and I are going to be on. So maybe after that, I can circle back with you and or Ken.
Sure. Yeah.
Yeah. Because
Might be on the call.
Oh, good.
One of us will be on the call, probably him, but I might be on. But yeah, that sounds good. And Jessica, thank you so much for the time. I know you're crazy busy.
Yeah.
So very much appreciate it.
Absolutely.
Well, thanks
Thank you.
everyone.
Yep.
Thanks, Stan.
All right, Ken, I'll look to follow up with you. Appreciate it,
Okay.
man.
Okay,
Okay,
thanks. Yeah, we'll figure it out. And Jessica, thank you very much, my friend. You have a little good time. It was absolutely perfect. This is, quite honestly, yesterday, and this is the hold on, I'm going to stop.